Hi, I'm Associate Professor Nicolette McGuire, and I'm so glad you're joining us for this recorded session of our Meet the Clinical Coordinators. In this conversation, I'm joined by Ms. Kristen Cullen, who is Clinical Coordinator for Western Australia, Dr. Tree Slater, who is Clinical Coordinator for Queensland, and Professor Patty Dewan, who is Clinical Coordinator for New South Wales and Southern Australia, as well as Dean for Australia and New Zealand. If after this recorded session, you have further questions about clinical rotations in your state or about any of OUM's programs, please get in touch with your admissions counselor, and they'd be happy to put you in touch with the right individuals and ensure that your questions are answered. Thanks, and I hope you enjoy this conversation with our clinical coordinators.
Was there to watch a baby being delivered in a car park. Yeah, that was a little bit unexpected and fun, but it really was amazing for that student to be able to be there and see it and have the ED consultants rushing out and catching the baby. Being a part of that from the get-go. As soon as the woman was on the pavement, unfortunately, the student was there watching. The students get to go in theatre, and depending on each surgeon, they can help out as much or as little as they want. I think having everyone at one site is very beneficial, because not only do OUM students build that relationship together, but they also interact with other university students. So I think that's really positive, and a lot of them have made connections and are doing OSCE preps together and those sorts of things. I think also being a smaller hospital, being a med student, it means you're not going to be the 5th, 6th, 7th in line to help in theatre or to catch a baby or those sorts of things. So I think there are pros and cons, obviously, but I think a lot of cons, being, you know, over here in WA, smaller site with not so many students.
Thanks. Tree, I know that you had to step out of the clinical skills course and that you're giving a lecture in it today. And we had a few questions in our Q&A about the clinical skills course. So maybe I'll just ask you this question about, students who are about to go into the clinical skills course. What advice would you give students that are in the preclinical years to help them prepare for clinical rotations? And don't forget to unmute yourself first.
So I was just about remembering. That's a really good question. I would say make sure that if you haven't got a good, solid relationship with your mentor, that you have one before you head into the clinical skills course. Your mentor is the person who's going to be able to help you make sense of a lot of the experiences that you have. That and your supervisors, but your mentor is going to help you do that longitudinally across your clinical rotations. So I think building that relationship and making the effort to make those connections is a really good way of having a solid foundation. In terms of preparations for the actual course, it's an unfortunately, the face-to-face part is an unfortunately small and concentrated experience that in the design of some other courses is spread out over a much longer period of time. So things like getting your reading and viewing of your clinical skills, your clinical examination skills texts, get onto YouTube. There's various different videos. There's lots and lots of people out there who will show you, good examples of the various different clinical examinations. And practice. When I was a medical student myself, heading into the clinical years, I learned the skill called percussion, which is tapping on your finger to see how hollow something is, for those of you that may not know that. And we use that when we're examining the chest and the abdomen. And our family had a dog that was very tolerant. So our poor dog got percussion of his chest most nights while I was learning to actually listen and hear the difference in the tones, because it was a very difficult thing to first take on, the difference. And then, you know, I did lots of practice, and my dad was a surgeon, and he said, oh, percuss the table, tap on the tabletop and tell me where the table legs are. Find them from the top without looking. So there's little things like that you can do that you don't have to be in the clinical context for, that help you hone these little subtleties of clinical skills. If you've got a good friend or family member that will let you practice using your stethoscope on them, do that. Because it's nice for it not to be the very first time that you've ever used a stethoscope to be in that more exposed clinical context. So in terms of that sort of preparation, yeah, good relationship with your mentor. Read up and watch up about your clinical skills themselves. Practice, if you happen to have the privilege of being in a clinical environment already with your current career and you're still working in that, then just do observe and reflect on what you see the doctors doing and on the difference in the doctor role from your current role, because that transition into that medical professional role there can be subtle differences, but important and significant differences nonetheless. So that's the advice I would offer. I'm sure there's further advice to come from the panel.
I think a lot of people are taking stock of whether their dog would be tolerant.
Not everyone would have a tolerant dog, but you know, maybe you have a tolerant partner or a child.
Thanks, Tree. Patty, Richie has a question in terms of preparation and Professor Dewan's advice about forward planning. And I know Teresa was talking also about trying to plan a year in advance, and Kristen was stressing this as well. Are there specific areas that we as students need to arrange? I'm thinking about insurances, sequencing of rotations, planning while we're still in the preclinical years, etc. I do love a planning question. So do you have a response to that, Professor Batty?
Yeah, we have wonderful people at the administrative level, Kristen being one of them, and Heather in the Brisbane office being the other two. And what they help us as coordinators and the students is to put in place things that move those rotations forward. It's towards the end of the preclinical years that you need to start becoming active and communicating about it, and not getting too concerned about it now, because we really have things pretty well in place so that the rotations can be organised proactively. So, for instance, for my own clinical involvement, I've got students assigned right out to September. So, and that's what Heather has done for the students in Victoria, and what Anne has done for students who are from Queensland as well. Some of the students are coming down here because they want to, and because of the opportunity they see here. And in some rotations, there's a little bit of a limitation in Queensland. So coming down here, and New South Wales students, because they want to see a bit of paediatric surgery, for instance, or they've got some family connections that they want to spend a bit of time in Victoria. So there's that kind of flexibility. Anne and Heather and Kristen know better than Tree and I the paperwork that needs to be in place. So they're the go-to people to say, have you got your working with children check? Have you got your insurances in place? The university has its insurances in place. And that is, you're assisted through that process. And somebody asked the question about the APRA registration. Being a Samoan registered university, there is a different process to Australian university students. And what it involves is the clinician to whom you've been assigned, they send off a cut-paste email to the national regulator, which then puts you on their books as part of what must happen for medical students coming into the workplace. So that process is not as we want it, but it's well-oiled and it works for what we need to do as a university and you need to do as a student.
Thanks for that. So the moral is that you don't have to know everything in advance that you need for your clinical rotations, that there are supports in place at the university so that all of your paperwork will be in. So thank you for that. So there are some questions about, what comes next for OUM students and whether they're whether they are able to secure internships and whether they're competitive. So can you talk a little bit about that? Do OUM students go on after clinical rotations to become interns, and where do they get to have internships within Australia? Maybe Tree, you mentioned one example of an intern who's coming in today, so maybe you want to start with this question.
Sure thing. Well, the intern that I'm bringing to speak to the CSC students today is actually the third OUM intern that we've hosted at our hospital. So there's a little bit of a pathway starting there, a little bit of a trickle. Really, certainly from the point of view of the Queensland experience, the intern recruitment campaign in Queensland does accept international medical graduate applicants. Not every state's campaign does that. There is also a sort of secondary campaign with the Commonwealth and private hospitals that does accept in Queensland, that also accepts applicants. But the process for actually gaining the internship is done later in the year than the domestic students. So the domestic students have a guaranteed place, and that all has to be processed through before the remaining places are then available via a merit-based process. So our OUM students, they need to have passed their AMC Part 1 to be eligible for registration with APRA. So that's a multiple choice question quiz with the Australian Medical Council, and then they go into competition with all the other candidates who are not what we call the Category A domestic candidates, and so involve CVs, references, sometimes interviews, yeah, the jobs there are some jobs there. It's not as straightforward a path as a domestic graduate, but it's certainly not impossible. And once a hospital and health services had a good experience of an OUM graduate student, they are usually more open to considering applications in the future. But it has been a little bit of a one by one sort of process, certainly from my knowledge in Queensland. We've got a graduate up in Townsville at the moment who did a lot of her placement alongside JCU students, and she's actually coming on board as a mentor and supporter. She's got a job in Townsville Hospital now. She's in her 3rd or 4th postgraduate year, and she's coming on board to try and champion opening up that pathway as well. So it's not impossible, but it does take a bit of work and a bit of dedication, and you may find yourself in late application or later in the year application situations, or even starting mid-year and out of cycle from the other interns. Does that answer the question?
Thanks. Kristen, I saw Kristen shaking her head. Maybe you want to field that question as well. Go ahead, Kristen.
Sure. So Peel Health Campus, we have just started to employ a very small number of interns. We've got 2 starting closer to the end of this year, and they're both OUM students. We've really pushed because they are such good students, and they've worked at Peel Health Campus as a student for the last 12 months or so. So we really want them. It's not, unfortunately, we can't take big numbers, but we will have them after they've successfully completed their AMC, MCQ. There's also Joondalup Health Campus that I know once a student has completed AMC, MCQ, they can apply for an internship at Joondalup, and they do the work-based assessments, which replaces the AMC clinical exam. So I know of at least one student who will be applying for an internship at Joondalup once they finish their clinical rotations. Like Tree said, it's not easy. It can be a little bit tricky, but if you're building relationships and contacts and networking, and there's always opportunities. So I think our students, it might be tricky for some, but I think they'll get internships and they'll find their way, whether it's through the work-based assessment program or another way.
Kristen.
I
know you want to ask this question, answer this question too, but I'm going to add an additional one for you, which is, when do you think that students need to start preparing for their employment? Oh, so go ahead.
Sorry, I missed the last bit of that. Start preparing for
The employment.
I muted myself. When along the medical student journey do you think people need to start preparing for internship and being a registrar? So I'm going to add that question. You can answer the other one as well.
So just the first question about getting the internships. The students who've come past me, so now that I've become into the dean position, they're kind of all my flock, but the initial flock from Victoria, they haven't had any problems getting internships. They've had to actually reject an offer to take one that was better placed geographically for them as one particular. The complaint now is the exhaustion from the fabulous time they're having in their new position is the only complaint I've heard about getting intern positions. And interns who have gone from Victoria to South Australia to Modbury and Lower McEwen, which is where we've got rotations now happening. There's a mother and daughter couple that the mother has come into her career rather late in the day, and therefore it's been a little hard for her to climb to the stellar performance of her daughter. But the pair were offered both a position because the daughter was doing so superbly well. So you guys are popular out there in the workplace, and particularly as students. So we often get the feedback of saying, yes, we've got medical students, but can we have more of yours, please? Because people see that you're a lot more dedicated. And I had a conversation with a paediatrician in Sydney last night who made that very point. I'm sick of seeing students who don't show up to their learning sessions, their teaching sessions. I want OUM students because they are really there because they want to be there, and they're very passionate about the medicine. When do you start preparing? When you decide to enroll. So when you walk into a hospital, just fantasize that you're the doctor. So the best way for somebody who is a stage performer, there's a lot of fantasy about the role to make sure you do it really well. And medicine, I think, is the same. If you want to be a really good doctor, when you go into a clinical rotation, behave as if you are the doctor, but be courteous to the patient about your knowledge limit and courteous to the professional about your relative knowledge, but behave like a doctor so that you can become a doctor. So when you enroll in OUM, start thinking of yourself as having the title at the end, not any of the arrogance that might be seen in some, but that sense of this is how well I want to perform. Great question. Thank you.
I'm gonna ask for some more advice from you, because this is a question I ask to all of our panelists when we have these Meet the webinars, which is, what advice would you give to prospective students who are here today and who are thinking of applying to OUM? So we'll start with you, Patty.
If you have a sense of wanting to look after people and you're wanting to do things really well and be self-critical so that you end up being the best doctor you have ever met. If you have that sense of that's what you want to do, if you want to have a medical degree, go somewhere else, please. If you want to make a lot of money from medicine, well, good luck with that, but wouldn't you rather be happy doing medicine? And yes, you can. You might become very wealthy in your medicine and do really good work as well. But if the primary aim is earning money, if the primary aim is getting the degree, then if you want to be happy, go somewhere else, because you can be really happy doing medicine. Patch Adams taught us that you get your energy from the patients, and that's what I would commend to everybody. Get that feeling of reward from that smile on the face, that tear in the eye that comes from the patient or the parent that you're treating.
Thanks for that. Kristen, what would you say? What advice would you give our prospective students who are thinking of applying?
Well, I mean, I'm not clinical, in any way. I'm purely admin, but I agree with Patty. I look at students and I decide whether I would let them treat me or my children. So I think the passion, I think the wanting to help people, I think all of that makes a good student. I think it definitely boils down to why you're doing it. Why, do you want to be a really, really great doctor that people are going to want to, they feel comfortable, they would happily let you treat their children. I think that's probably the best advice that I could give.
Thanks, Kristen. Tree.
I definitely echo what Kristen and Patty have said, and my own driver in terms of staying in medicine, being in medicine, staying in medicine is the intense satisfaction I get from the process of demystifying disease. It's that communicating across, and also as an emergency physician, I get the privilege of being next to people who are having the worst day of their life. You don't go to an emergency department on the best day ever. And it's a real privilege to stand next to people doing that. I can't help but let my Scottish roots show here and say, get your finances in order, get your finances planned if you're going to be a medical student. That's a really, it's a really, a fundamental thing. If you can't pay the bills, you can't progress the course. So be organised, be forward thinking on that, and as much support around you from your family, friends, and community as you can muster. I would say, because it's not something that you take on lightly and that you do just in what's left of you. It is quite all absorbing. And you do need people around you to remind you to take a breath, to look up, to enjoy the sunshine, and to look after yourself as well. So it takes a team, it takes a village.
I'm going to go off topic just really shortly, because I know, Patty, you've just returned from Mozambique, and I just wondered if you wanted to say a few words about Kind Cuts for Kids.
Oh, thank you. Talk about my hobby, that's great. Kind Cuts for Kids is an organisation where one of the things, the connection to OUM is we've had the privilege of one of the New Zealand students taking a rotation as part of one of those missions into Kosovo. And that student has since organised to do one of her elective rotations, I think in cardiology, back in that country, because she's proficient at learning language. She spent some time in Holland, I think, in the past, and therefore international reaching out is what she's able to do. So that's been an OUM opportunity out of Kind Cuts for Kids. Kind Cuts for Kids, what it's taught me by outreach trips like Mozambique, which is it's trip number 139, and it's coordinating surgeons, anaesthetists and nurses to be involved, but it's usually a lean, mean fighting machine. So I was the only person who went to Mozambique because I want to learn as much as I teach. So learn what works in their country. So for instance, the diathermy handle, so that's the tool that you use to cut with electricity during surgery. We use them only once in our countries. In Mozambique, they soak them in antiseptic and use them again. So the electrics fail fairly quickly, but they can use them 2 or 3 times rather than just once. But the hands and heads, knife and fork teaching that I do taught them, they had a whole bunch of out-of-date sutures. And sutures don't really, that's a material to sew the patient up with. They don't go out of date apart from the possible becoming unsterile, and they might be a little more breakable, but the company puts a very short time on their usability so that there's no legal problem with it. They're usable well beyond the date that's put on the packaging. So they were putting these on a shelf and not using them, and instead sewing up the wound with silk sutures that were outside the body, which increases the infection risk, increases the scarring risk. So I was able to teach them, you can use that out-of-date suture. So just that little maneuver will result in significant improvement in clinical care in Mozambique into the future. And that was just the tip of the iceberg of the sort of enormous changes we were able to make in that one country, and we've been to 23 different countries. So I would commend outreach as a way of learning and giving back, and hopefully we'll have rotations available. And somebody mentioned in the Q&A about the Samoan rotation. You're expected to do 4 weeks of rotation as an elective, and we need to be selective about, if you go to Samoa, we need to make the education able to come up to the standard of OUM internationally by getting some Australianisation for those students from Australia, some New Zealandisation for those who are coming from New Zealand, so that our plan is to have a mentor in the country of origin to assist with the learning that is the clinical exposure. It's fantastic in Samoa, but to have a mentor in the country of origin so you doubly learn, so that you can apply those learned skills into the environment back in your own country. So it's a real win-win scenario. And the Red Cross Children's Hospital in South Africa, there's a regular webinar available out of the Paediatric Surgery Department, and there are rotations available into World Best Practice organisation in South Africa as well. And there will be lots of those other elective opportunities that will be able to be opened up because of the association of AUM and Kind Cuts for Kids.
So we'll make those links available to your admissions counselor. So if you'd like to learn a little bit more, you'll be able to do that. So we're just at the end of our hour together today. So I know that those of you attending today will join me in running such a warm, hearty thank you to our panelists, Professor Patty Dewan, Ms. Kristen Cullen, and Dr. Therese Slater for joining us today and sharing their wisdom. You can see that they have incredibly important roles at OUM, unless their time is quite limited. So we're really pleased to be able to bring all 3 of them here today to speak with you. So I also want to thank each and every one of you for attending and being part of the OUM community today and sharing your questions. If you didn't have your question answered today, please get in touch with your admissions counselor, and they can ensure that that question goes to the right individual and you get a good and fulfilling answer to that. So thank you again, panelists, and to all of the attendees, and a special thank you as well to the admissions team for making this happen. So we hope to see you all in classrooms and on clinical sites soon. Thanks so much for coming, and see you all again.
Thank you. Bye.
Good.
Thank you.